Welcome back to BioInsights, uh, where if you're new to the channel, it's about sport tech, longevity, fitness training, research, and applied practice. Today's topic, I'm really excited to have a conversation about. Personally, I'm an advocate of the tools that we're going to talk about today. Blood flow restriction. It's a great tool to have in your bag or your PT bag. It's every person's going to get hurt at one point, and it's a great tool. If, let's say, for example, as a clinician, you have someone from ACL surgery that it might be, or is maybe 70 years and older, they can't lift heavy load anymore. So, as a competitive athlete who's overtrained and needs to maintain muscle without adding type of stress to the system, this really allows for clients to have the ability or the benefit of training. And to help us kind of get started, I want to welcome a really important person that's going to share his story as well. So my guest really is focused on BFR work everywhere, from watching ACL reconstructions to NCAA weight rooms. He's a continuing education course provider, and he's worked with 1,000 clinicians. Dr. Mike MacPherson, welcome to BioInsights.
Yeah, thank you for having me, Marcelo. I greatly appreciate the opportunity. Excited to talk about BFR with you.
Yeah, I wanted to kind of have this discussion because I've spoken to other professionals in the market space. I've actually did a BFR episode already, and it's really interesting because there's so many ways of doing BFR, and there's so many tools out there of BFR, and I think getting another perspective, that an understanding, of how we can kind of set this table maybe is, what I would hope anyone could walk away from here with is an idea of why BFR and what is it, and
hmm
more importantly, what's some of the research that and to kind of um, debunk certain myths, like
Yeah,
it's in some cases it's safe. In most cases it's safe. It's evidence based, and in some cases it's FDA cleared too. So I think people need to understand a little bit more about that. So, you know, let's start with your story. You played college football in Michigan Tech. You moved into the strength and conditioning field.
hmm
You spent decades in high school weight rooms. Um, you, you've operated these rooms. You've also been in reconstruction areas. With medical doctors of surgery, which is one. I want to know how that is. I've never done it myself. Um, can you describe the gaps kind of between applied practice and research?
yeah. Well, starting off in the classroom, was teaching college and high school classes, and I've taught every science course that is offered in the state of Michigan: anatomy, chemistry, physics, biology, all the advanced, all the rudimentary, up and down. Doing some of that in the college ranks. Then I went back to school, earned my doctorate, and that's when I got that opportunity to go into the operating room with Stryker in their sports medicine. Incredible being in there, watching those things happen, right? When they're taking the graft for the ACL reconstruction, meniscus repairs became routine. You're in them every day, Monday through Friday. Some of the
Wow.
coolest things I remember seeing was foot and ankle surgery. And one of the things that really stood out to me, and kind of lead the segue into BFR for the foot and ankle, and how incredibly important it can be for everyone, healthy, non-healthy, injury, non-injury. But there was I was watching a surgery. It was for adult acquired flat foot syndrome, and I was like, "Whoa, what's that?" And so I started talking to the the surgeon, and he's like, well, the muscle, it doesn't contract anymore. So all they did, right, to rebuild this arch in the foot, made a little slit. They pulled the muscle taut, right, cut it, pulled it, drilled a hole, and dunked it into that hole, and it just created that arch. And so in my mind, I was like, oh wow, that's strength, right? Like that's a lack of strength right there. That arch has just been beat down, whatever it is, and it's just completely lost all its integrity.
Was it
Um,
tendon? Were you talking the tendon was
yeah,
slack, or was it the ligament?
the muscle belly into the tendon where it attaches, and they just cut it
Wow.
and pulled it. And I watching that and was just thinking to myself, like, wow, this is a strength thing. And I'd always go back to when I'd be watching these surgeries, rotator cuff repairs, FAI in the hip. I'd be thinking, what can I do to, I'd always go back to my strength because that's apparently, that's where my heart's at. How would I rehab this athlete? Because I saw 19-year-old hockey player femoral acetabular impingement, getting the neck of their femur spun and taken down. And so I'd be watching, all right, what would I do to rehab this kid to get him back to playing and to make sure he plays safely? Then I was very fortunate. I got a call. I was actually in the operating room. I was in a shoulder replacement, and they no longer needed me in there. My portion was done. So I was like, hey, go out, go to the next one. Got a call, went to the locker room and took it, and it was a BFR company. They're like, hey, hello, who is this? What can I do for you? Based on your experience in the weight room, rehab, your doctorate, and everything you've learned, we think this would be an opportunity for you. So it's like, I don't know anything about BFR. I would love you got any literature for me, pass it my way. Started digging into it, and I was just shocked, right? I'm a CSCS as well. Been to national conferences, regional, state, local, and I'm like, how did I not hear about this? This is a hypertrophy hack, full go, full tilt. Um, so start learning, start working with different teams. Fast forward a little bit, I'm working with a lot of our professional sports teams, 80% of the sports teams across the United States. And I started having really great conversations with people where we're just sharing, right? Talking shop, learning from each other. I'd be like, why aren't more people doing BFR? Like some of our soccer academies, you saw it a lot at the top tier. Then there wasn't as much below at those lower academy levels. And I'd be like, what's going on? Why aren't we seeing BFR there? And like, they just don't know. They're not getting it in school. They haven't been certified. They don't feel comfortable using it. And so that's when I founded clinicalbfr.com. And that is something really working hard to build out in advance. We're going to provide protocols, basically everything anyone needs to perform BFR, adolescents to elderly. But that's when I built out this course, got certified with the APTA, the BOC for athletic trainers. And when I was digging, like I probably read easily 400 articles this past year on BFR. And I realized reading these articles, like, whoa, there is way more than just athletes and ACLs in here. Like you start, right, just this information age we're living in with how easy it is shared. Older adults, longevity, sarcopenia, osteoporosis, adolescents respond incredibly well. And you're just able to see what they're doing in other countries, in the hospitals and those types of things. And one of the biggest things that I've found that I would like to share, kind of set the stage. Granted, I'm I'm bonging the BFR Kool-Aid. If you have a pulse, BFR has a place for you. Because at the end of the day, right, I lifted this morning. You can't always lift heavy. And I'm 38 years old in my recovery, right? Like if I lift heavy Monday, Tuesday, my Thursday, Friday, you better be working on more explosion. You'd be working on more form, technique, because you're not going to be able to go. I'm not able to go as heavy, like full tilt, get metal to the metal all the time. So that's why I had BFR, or I'm using it to enhance my recovery after a lift or to warm up before a lift.
I think I am full agreement of the longevity and the health span point. I'm much older than you, and I use it. It's kind of funny. I've heard it used phrased this way by an NC State coach that I worked with. He said, "It's like bacon; it goes on everything."
Yeah.
Uh, and I chuckled, and I was just like, "It's hilarious, but it's really true." To get a little bit, I think the disconnect for the community is obviously it's safe. We'll talk about that. Um, the physiological aspect. People say, well, how do you get hypertrophy or how do you get strength from this through occlusion when it's a not a mechanical stress that causes this, but a hormonal stress? And how does that hormonal stress lead to supercompensation?
Yeah, yeah. So we're good a little science here.
Yeah,
Because
we're geeking out.
this loads the toolbox with tools. Because once when I talk about the science, that's really what my course focuses on too. Like lay the groundwork. So I'm obviously an old science teacher, and that's what I'm super passionate about. So I was like, I want to know every mechanism that's happening here. And the way we teach, we go in depth into the science, but in a very digestible way. And I've had countless people reach out and they're like, I know all of the different ways I can use this now because of
Yeah,
the way you told the science. So at the end of the day, hypertrophy, right? Still the theory of hypertrophy, muscle damage, mechanical stress, and metabolic stress, hypoxia, lead to stimulations in muscle hypertrophy increases in muscle protein synthesis. Okay. When we do heavy load, high intensity resistance training, technically, right? I guess there's some muscle damage there, but it's the environment that those reps and those heavy loads create that makes us stronger. It's the muscular environment. And those weights cause a change in the muscular environment. The effect or the answer to that change, the body stimulates an increase in these anabolic hormones. By taking a BFR cuff, right, and applying it to the most proximal portion of my limb, as you know, now, right, this is automatically, by inflating this is going to cause a decrease in oxygen. So it's going to create a hypoxic environment. And we'll go into the incredible things that happen in the body with hypoxia, because that alone hypoxia alone should be why we're doing BFR with everybody, and we'll go into that. But then this creates mechanical and metabolic stress, and the way it does that is I'm slowing down blood into the limb, right? So I'm going to reduce the amount of blood going to the limb, so I'm going to bring my oxygen level down, and what that does, very amazingly, is the reduction in oxygen causes an increase in type 2 muscle fiber recruitment. The body doesn't want to recruit type 2 muscle fibers early when you're normally lifting, right? That's why you got to lift heavy, because they cost a lot of energy. So the body will put it off until you force it to recruit type 2 muscle fibers with a heavy load, right? High force production till that need's established. BFR hacks that Henneman size principle, right? Which says muscle fibers are recruited smallest to largest. With BFR, because we change the muscular environment and we reduce oxygen, the body can't use the type 1 muscle fibers, which need oxygen. They get shut down. It's got to go right to type 2. And now we're getting stronger with lighter loads because we are forced to enhance type 2 muscle activation. We have what is called occlusion, or we're stopping blood from escaping the limb. So that's our venous outflow. So what happens, right, we'll go back to hypoxia, but as blood is prevented from escaping here, it's got to go somewhere. So it starts pushing into the muscle cells. One, it'll push into further reaches into the capillaries, right? So it'll get more distal, right? Get deeper into the fingers and deliver blood to areas that might not have had blood as efficiently as they should have. But what happens is it pushes into those muscle cells. Those cells start to stretch, and that registers as what's called cellular swelling, type of mechanical stress. At the same time, where metabolic stress is accumulating because those type 2 muscle fibers are contracting, they're producing phosphate, hydrogen ions, lactate, reactive oxygen species. So all of that is pushing into the muscle cells. That metabolic and that mechanical stress, that cellular swelling, stimulates increases in testosterone, growth hormone, insulin-like growth factor, and muscle protein synthesis. And the real simple way I like to explain it, that cell membrane feels that stretch, and it tells the nucleus, I'm under tension, this is stressful, this is straining me, we need to grow bigger. So then the nucleus, in response, is like, all right, upregulate the hormones that increase muscle protein synthesis. The metabolic stress that builds up, that just adds to that, just continues on with that increase in growth hormone. Now, the most important thing in my mind, personally, I think is hypoxia. oxygen, and this is why I think everyone should be doing some sort of BFR, whether it's passively or actively. Oxygen, so hypoxia is a reduction of oxygen in this environment. Now, oxygen is incredibly important to the human organism, so it is tightly regulated by our tissues. There's sensors, you could call it, right? And that's really simplified because these are amazing biological things happening in our body. There are sensors that as soon as oxygen levels drop, your body turns on what are called hypoxia-inducible factors. And they are master regulators in the human body. And so what they do, that oxygen level dips, these things start getting created in the blood, and basically they're at the control center, and their whole job, they start boosting all kinds of other hormones. They turn up the awesome. We'll call it that, right? They're going to turn up everything. So
Best way.
that's it, man.
Yeah.
Hypoxia-inducible factors, they end up increasing, right? They stimulate BDNF, which is brain-derived neurotropic factor, right? And we're finding in studies cognitive health, learning, memory, cognition. That's why some of our NFL teams, some of our college football teams are now using passive BFR with post-concussions. Also why we're seeing more with like nerve issues, the use of BFR to help those things because it heals the CNS. We see increases in vascular endothelial growth factor due to the hypoxia-inducible factors, and that it stimulates new blood vessel growth, right? Amazing. Cardiovascular. And then hypoxia, or that reduction in oxygen, also turns on heat shock proteins, which is all that rage from the sauna, where you see more of those portable saunas. And those
Yep.
heat shock proteins, incredibly effective against chronic disease, right? So their job, they're like the builders of the body. They take a look at they look at the blueprint of a protein, and then something very important, this is where I really rely on my biology background as a teacher, is one of the central dogmas in biology in the body is structure dictates function. The structure of that protein basically says you're built like this, you do this job. Well, if the structure has been changed and it's not appropriate, that heat shock protein looks at the blueprint, says no way, and it tears it down and rebuilds it, or to replace, recycle. So those things alone, right, in my mind, just the act of reducing oxygen is like we can get some BFR on somebody, get them to 30-40% LOP, because I've had great results. This is a lot of anecdotal stuff, and we're seeing it more in the literature, but lower pressures for older adults, that's where it's at.
Yeah, and so great job in explaining the why and the what. And I love the teacher in you because I'm also my bachelor's of science is in PE, but I
Yeah.
taught biology. I also taught health, so
Oh,
I
that's
get
awesome.
yeah. Being an educator, I always love trying to explain to people. It's like people come back and they're like, "Well, you can't get hypertrophy through it because it's not mechanical wear and tear, but there's a whole other you can't throw out the physiology without so you're talking about the chassis as opposed to the engine. They
Mhm.
both need to be in a car for it to be working, so one doesn't
Yes.
take independently. One doesn't take action without the other. um,
Mhm.
so some let's talk about some use cases here. So BFR should be included into programs. It's not the only thing a person should be doing. um, it enhances everything. Um, I've seen a couple of protocols out there, 30, 15, 15, 15. And then the other protocol is basically time-based, duration-based. There's some suggested cap-offs, right? People say don't do more than 20 minutes of BFR work, right? Perfusion, leveraging perfusion in a training program. In other words, increasing pressure and then all of a sudden decrease in your recovery period, crank it back up again and go through another circuit. Um, Doing contrast training for this, benefits of that. A recovery tool. So I just placed a whole meal in front of you of options that you can go to. I would love to hear something that is around the 30, 15, 15 compared to more, because it's grueling. People, you have to understand 30, 15, 15. Make sure you pick the right weight because your ego will be checked at the door. If not, you'll learn the hard way because people are like, oh, I can't get sore from this, or I can't, this is not a hard workout. Try it. That's the best way. And from a reconstruction standpoint, I would love to hear a good story around knee injuries, meniscal tears, or ACL tears, and the benefit of that. So let's start off with a strength training one. What comes to mind just based on those examples?
Yeah, so 30, 15, 15, 15 is what you're going to see most of the peer-reviewed literature up until I'd say 2022. That's what a ton of it is. And you know what? When you start talking with people and they trust you and you got a good relationship, that's not what everyone's doing. Um, right? Because same, yeah, um, 75 reps is a ridiculous amount of reps, right? Like I
Yeah,
would never, you're going to tell me I got to squat 75 times. I'm probably not going to be walking
yeah.
for 3 days. That's not going to be comfortable, right? Like that's just not good for business.
At 30 or
Um,
40% of a 1 RM too. It's like,
right? Like still. Oh.
yeah,
So what really changed, what really added fuel to my fire and gave me the proof that I was looking for to really kind of scream this from the mountaintops is there was a meta-analysis systematic review in 2024, and they looked at BFR rep schemes, and they compared multiple sets of 15, 2, 3, 4 sets, typically 3 to 4 sets, to that 30, 15, 15, 15 protocol, which is now becoming commonly referred to as like the 75 rep protocol. No difference in outcomes. Strength, mass, endurance, no
no,
difference in outcomes. And the thought, and so they hypothesized, and they did another study, and that was based on the ceiling effect of BFR. And basically, because now we're seeing studies that are showing 30 to 80%, 40 to 80%. There
yeah,
might be some huge differences there. I'm sorry, not huge. There might be some differences with what's going on in the blood, but when it comes to the eventual outputs of muscle mass and hypertrophy, it's not huge. And a lot of times they're pretty much on par with no significant differences. There's basically a window for BFR. And once we get into that window, right, we achieve that minimal threshold, we're boosting all of those anabolic hormones, right? We can continue to boost, continue to boost. And then if we continue those reps, eventually we hit the anabolic ceiling. Either we basically just, right, we've dumped enough into the blood or we've filled up all the receptors and they've just become saturated. Because what they hypothesize is that's where that multiple sets of 15 hit. And then if we do those additional reps, what we're adding to, and this is what this is what makes me hypothesize, this is where all that DOMS comes from, because I don't really get DOMS to do BFR, is because they're doing 75 reps, right? There's your massive increases in muscle damage because you just keep repping that out. Even if it's a low load, you're still doing that 75 times. Or three exercises 75 times. So traditional, new person, older adult, honestly, I'm going for 3 different exercises, 1 set of 15 each. I want to build my thought process. I want to lay the foundation. I know how beneficial BFR is. I know I've seen the incredible things it does. So I'm never trying to scare right? I'm not trying to scare you away. I want you to come back and I want you to find some enjoyment in this, right? I'm not trying to blow you out. I've done that. I've made that mistake as a younger coach, and it does no good for anybody, right? People they don't fall in love with training when you do that to them. So, and this is to me, right? As you said, longevity. This is the rest of your life thing. We've seen what it looks like when people stop moving, the
mm,
posture, the lack of independence. You're relying on a lot of other people to just do your daily physical activities. My goal is to help, right? Our generation, the next, and so on. Keep moving, right? Motion is lotion. Movement is medicine. Stay on your feet and let's keep you strong enough so that you can age gracefully and independently. And so that's where I really think BFR has its. That's where I start with strength wise, and then I'll slowly increase. Isometrics, obviously we'll do a lot more of those for time. So like three sets of 30 seconds. And we'll combine those. So I read a book. So this is where it kind of comes to, especially the foot and ankle stuff, which was huge. Read a book by Cal Dietz,
no,
Minnesota strength coach, called Triphasic
all
Training.
phasic training. Yeah,
Yeah, and he broke it up into all those like 3 to 4 week blocks of training, if I remember correctly. And it was like concentric, eccentric, traditional, isometric, and then straight eccentric training. And I was like, okay, what if I combine them? So we'll do a lot of our foot and ankle. We'll do like 15 heel raises. So we do straight leg, and then we'll do knee over toe heel raises. Because straight leg, I'm hitting my gastroc. Knee over toe, I'm going after the soleus. And we could get into all that down that rabbit hole, how they tie into the Achilles, and I think that leads to ruptures. But we'll go 15 reps of straight leg, and then we'll take it to the top and hold isometric for 30 seconds. And with BFR, it's next level. You tap right. The calf is very hard. It atrophies super quick. It's hard to build, and those muscle fibers were meant to move. And those muscle fibers, especially because they're in our leg, they're meant to move for forever as much as possible, right? So BFR does a very nice job of hypertrophy, tapping in, reducing pain down there.
Yeah, I've used BFR in sled drags, backward treadmill walking,
Nice.
lunging, step ups, squat. I used it for 16 weeks. I just was using it like it was not a workout that I did not give myself an option because I wanted to see how, like, where I could put this into and get an understanding. Because to your point, it's been the traditional protocol has been 30, 15, 15, 15, 15, 3 15s, and then for time, and you kind of just mentioned it now, isometrics for 30 seconds. I've seen a lot of programming. There's two schools of thought. It should be based on repetition maximum, or it should be based on fatigue, right? So that's usually associated to a chunk of time based on the set principle, right? I'm trying to develop this specific intensity. Do you feel like BFR, because I've seen it now used in cycling or in team sports for skill development, or place it on them and have them do a skill to induce more, but at a slower pace, because to your point, heavy legs, still sore, can't get a heavy workout in, but I want to work on the foot skills. So I'm going to make sure I hit that ball, get so many reps, but go through the scheme I'm trying to teach, but I want to make it, hypoxic, or I want to reap the benefits of enhancing recovery with BFR. Can you talk to that a little bit?
Yeah, we do a lot of it. I do a lot of it with quite a few people. When it comes to like soccer specific drills, we'll see BFR commonly used, ladders, quick footwork, dot drills. And so the whole thought process behind it, right? Like, and you see it all the time. It's very Instagram, or if you're on the social media, ladder drills don't build speed. What are you wasting your time doing ladders for? And it's more of a footwork thing for sure. Coordination, which everything has a place. You're still building the foot and ankle strength, but then you add BFR to those things, and now we're increasing type 2 muscle fiber recruitment, and now we're doing a lot more. So you just amplified that ladder drill. And speaking with, because I've worked with quite a few professional athletes, and you'd be surprised how many of them are doing that, and they don't tell anyone about it. And I'm talking some of the,
Oh yeah.
Super Bowl winning quarterbacks and some people who move very well. They're combining they're doing all those footwork things, those short bursts. They're adding BFR to it. And as you said, Marcelo, right? The recovery, you're going to take that off. You're going to feel great. BFR walking, very popular, right? Traveling, legs are dead. You're just smoked. You got tightness in the low back, the hips, the calves. You put the cuffs on, you go for a walk. You put the cuffs on, you ride a stationary bike. Typically, what we recommend 10 to 15 minutes at 40 to 60%. Game changer. Absolutely renews.
You just look like the odd guy or girl in the gym. What the hell is he having his arm and legs?
You're like a robot.
I've done that. I've been in hotel gyms, and I've done recovery work, exactly what you talked about. I usually do it for like 15, 20 minutes because it's like I have a small period of time. I'm either working a show or an event. I got a beach somewhere, but I want to get myself going, you know. And if it's not a workout, I'll use it to your point. Like you talked about that protocol, 3 movements, 30, 15, 50. You could pick, a squat, a lunge, a push up, and bring a pair of bands with you to do any type of pull, and you're done. That's 20 minutes. So that's efficiency. And to your point, you don't have to have tons of equipment. Um,
No.
so that's what's great about the elderly population as well. And I feel like, um, recently I've been talking to a lot of practitioners on neuroplasticity and dynapenia, and like what bothers me is that we always talk about sarcopenia, but we don't talk about the real lead indicator, which is the nervous system.
Yeah.
So dynapnia happens as now it's showed like as the age of 30, so that's the nervous system starting to just lose the ability of fast twitch muscle fiber, and it starts dying off unless you use it. So, but the research shows that after the age of 70, they took a cohort group and they showed that just applying a strength training program, they were able to regress that. You know, this is where I think, products like this and blood flow restriction, there's so many different types of options, right? You have the bands, you have the elastic straps. Well, not they're elastic, they're straps, I should say.
Yeah.
And the difference is you talked about venous outflow, the arterial going back, I guess inflow, right? Um, does it matter what type of strap or band you use?
I I think so. A lot of my results, and I've used a lot of them. I've dabbled, right? Because I like to experiment on myself. If I'm going to talk to someone about it, I want firsthand experience. No matter what it is, I want to have tried it for myself. I've used some very thin strap-based cuffs, right? So they don't. So obviously, in my mind, the gold standard or where we should be at for blood flow restriction is we should be finding a limb occlusion pressure, because that is what, just like we do a progressive overload in the weight room, we can do a progressive overload with the occlusion. We can kind of use the sliding scale. We get into that. But you want to find the limb occlusion pressure, the LOP, and that is the minimum pressure needed to stop blood from entering that limb. So I guess let me back up, because I forgot to mention this when I was in surgery. The gold standard for tourniquet time during an ACL reconstruction is 90 minutes. So they will
Wow.
have that leg, they will have that tourniquet on that leg for up to 90 minutes of 100% occlusion. So in BFR, you find 100% occlusion, and it takes a snapshot, right? Or the cuffs that I use, the Airbands, the Saga cuffs. It takes a snapshot of that pressure, and then it deflates. And it's just like taking your blood pressure, right? They inflate it, pulse is gone, that sensor no longer detects that arterial pulse. That's your that's your 100% LOP. And then we're always working to a percentage of that. All right. When it's an elastic strap, one, it's not, it does not fully occlude. So you're never going to get to 100% LOP. And elastic straps are typically thinner. And so what I've seen with and so what that means is the wider the BFR cuff, the wider it gets, you can actually slow down the blood flow at lower pressure. So you don't have to get as high. If you use a really thin cuff or a strap, the pressure gets exponentially higher. So you might not even get to the same level of occlusion of a wider automatic cuff, but you might be using 300 to 400 millimeters of mercury above the pressure. And a lot of those 5 centimeter straps I've used, on the shores that with the BFRs that strap, I've ended up black, blue, purple, and I do not bruise easy. And that to me, granted, it didn't hurt. I was like, God, I'm not hurt. I was like, but I don't know how many people would be all about this. Unsightly, end up purple and yellow. And so I really like something that automates my LOP, something I can put on, and it walks a fine line, because too thin, you get that bruising, that discomfort, all that stuff. But then if you go too wide, right, you sit right on the muscle belly. And now when you're working your bicep or you're benching or you're contracting your hamstring, that cuff sits right over that muscle belly and really disrupts that range of motion. So that's what I'm looking for in a cuff, right? Something about 10 centimeters for the leg, 8 centimeters for the upper body. And I want something that calculates LOP.
Um, I talked about perfusion before. Can you talk about that a little bit, and the concept of using, once you've identified that window like you referred to, Um, how do you use that to maybe stimulate, and why would you use that to stimulate? What's that hormonal outcome?
Yeah. Um, right. So one thing I wanted to, we'll get into for surely. So reperfusion stimulates another type of mechanical stress called shear stress. And so what happens is I got the cuff on and this blood, right? So like it's all occluded in here. And now the blood in the limb is lacks oxygen now, lacks nutrition, and so the muscle, although it's full of blood, is really starving for nutrition, and it's kind of building up a vacuum because everything up here, everything in circulation is full of oxygen, full of nutrition, amino acids, neurotransmitters. It's ready. When the cuff deflates, it's like a vacuum effect, and what happens is the oxygen rich blood during the reperfusion period rushes into that limb and pushes, right? Basically replaces all that metabolite rich blood. And so the oxygen rich blood accelerates through, causing friction in the blood vessels. And that further stimulates the release of nitric oxide, right? Which is a vasodilator. So it's going to widen out those blood vessels, let them relax, get more nutrition, more things deeper into circulation. And what else is super important, I think no one ever talks about, is blood doesn't just deliver nutrition, it removes waste. And when you have waste that just sits in one part of the body forever and never gets any immunity to it, to me, right now you're at chronic disease, cancer. Those things could potentially be festering because there's a lack of blood flow to remove those waste products and just keep right. And whether the alkaline, anaerobic environment, acidic environment that contributes to cancer, right? If there's no blood there creating that alkalinity, and you just keep getting more acidic in that region without any nutrition, that's where BFR pushes deeper and can really remove some of that waste. Now, when it comes to training, what we see most often in the literature is 15 minutes continuous in the upper body, 20 minutes continuous in the lower body. Now, are those set in stone? Absolutely not. It's just what we see most often. So that is what I recommend because that's safest. I've worn my cuffs for 30 minutes straight, right? I've exceeded that because I like experiment on myself and I've done this before, but that's what we like to see. And so in my mind, BFR, based on a lot of the pro sports and the conversation we have now, and the studies out there, BFR is very much a sliding scale. So, and what I mean by that is occlusion time and occlusion pressure. If I take my pressure up to 100%, we typically see no exercise, and we'll see passive BFR cycles. So they'll go 5 minutes on, 3 minutes off, and they'll run that 3 times. So they'll build up that occlusion, build up that metabolic stress, that mechanical stress, that hypoxia for 5 minutes. Cuff releases, oxygen-rich blood flows in, kind of resets. Typically, some of the studies have found you only need a minute for that capillary, that refill period. However, 3 minutes just kind of gets you a little more, I don't know, feel a little bit better doing it. If you do a minute, do it. And then you kind of run that over, you run that for 3 more cycles. And that's with 100% LOP. Now with like my older adults, right? And this is where I think BFR you saw was just like, it's only athletes and ACLs. Because everyone was trying to get everyone to do 80% and 75 reps. It's like, you out of your mind? You're going to ask my grandma to put on 80% on her leg and do 75 reps? So we bring that down, right? Bring it down to 30. And now I'm going to get you walking. I'm just going to keep you occluded for 15 minutes. And maybe, right, you're going to do some lateral raises, some bicep curls. And instead of deflating, I'm going to get you walking a little bit. So we just kind of continue to do some arm circles. So if they're tolerant of it, I will keep the cuff inflated. My goal is to get to 15 or 20 minutes. If we're exercising, we're starting off, and like, because I've done it to myself. If you really build up the lactate and then you take those suckers off, it can make you feel nauseous. If you get that lactate high enough, you're like, oh, right? It only happens, as you know, right? That moment happens, you're like, I overdid it.
Yeah, it's like, I wanted to do two other, protocols. I ain't doing that.
No.
It's dosing is really the learning experience, right? Because that's
Mm-hmm.
really it. It's understanding the dosing and intensity. And if you could identify that intensity, then you can implement it. So it takes time. That's why I
Mm-hmm.
think you can apply it to many different types of your program design, from your warm-ups, to your core exercises or accessory exercises, or just use it as a recovery tool.
Yeah.
Uh, and you know that the Normatec stuff has been comes for that. This is basically that concept, perfusion. So it's just implemented in a different way. I've seen it actually done with hockey programs and soccer programs when they're on the bike. What
Yeah.
you're just
Yeah.
some of them are cruel and we'll have them do the watt bike and program the watts on top of it. But I digress on that one.
Ooh.
uh, I think really, to kind of bring this all together, what are some, if people want to learn a little bit more about you and about BFR, where should they go?
Yeah. So absolutely on LinkedIn, I post a BFR article every day, summarize it, key findings, protocol. So be able to see what's out there with all the new research. There's lots to share, and I'm not even going back very far yet. I will start doing that. There's just so much being released on it. Clinicalbfr.com. That's my website. Certifications there, and that's also being built out with blogs where I can just share everything I've learned with everyone. How we're using it for the warm up. How do we use it for mobility, yoga, Pilates? A big one now, plyometrics. We do lots of BFR plyos, right? No additional tendon load, but increase that muscular, that strain, that intensity.
Explain the protocol for that.
So very simple, right? So that's where we're really relying on the strength and conditioning, like CSCS and the structure. So we're looking at 2 to 4 sets, and it's typically 3 to 6 reps. I like to stick with 40 to 60% LOP. And I really base this off of the amount of literature I've read where they've looked at cycling, explosive movement. And when they compare 60 to 80%, no difference in outcomes, but there is a difference in pain, right? You put the kids at 80%, they don't running. I mean, they're hiding, they're in a closet somewhere because they're not trying to do BFR with you. You put them at 60%, they feel the benefits, they see the benefits. It's not as painful. So we'll do box jumps, we'll do depth drops, we'll do some broad jumps with it, and just keep it explosive, keep it short, keep the repetition, the technique high. And again, we're only getting maybe 2 to 4 sets, 3 to 6 exercises, depending if it's bilateral or unilateral.
Size box, what are you going to?
So right now, 12 to 16, nothing crazy. But then obviously we'll scale, we'll get up to 24. And the whole idea is right, that tendon load's unchanged. So we're not running, especially if the kid's inflamed or dealing with any tendonitis or anybody. I got jumper's knee, this is painful. One, you're going to feel a whole lot better when you jump with the BFR. I beg you, don't believe me, anyone listening, go out and try it because seeing is believing. It greases the joints. My knees, my hips, my ankles, out the gate are heads and shoulders above when I warm up with BFR or do any sort of jumping with BFR versus not. So you just feel right out the gate you can jump higher, more effectively, or you just feel better doing it. And then with the BFR, right, no increase in the tendon strain, but we're adding more to that hypertrophic, the recruitment type 2 muscle fibers, which should see an increase in power force development.
That's great. I'm glad that you brought that up because I would have I would have had to I would love to talk about that in general, more use cases like this because I feel like a lot of people need to just have exposure outside of what you refer to as the Instagram. This is really cool to post. Um, I think we need to understand that these are all tools that you should have in your gym bag or your PT clinic bag. Uh, are useful. I mean, at the end of the day, especially if you're an aging athlete or all the way up to everyone at any age category could benefit from having this. So I think it'll be a matter of time. And I'm happy to see that we're both talking to the same community about it.
Yeah. Yeah, no, I love it. I didn't share it with you earlier, but a very recent success story. Um, I had a high school athlete tore his ACL, and he had 6 weeks before he had surgery.
Oh, wow.
So he had this 6 week window. I sent him home with a pair of cuffs. I was like, hey, this is what the literature says. Passive BFR. Let's aim for 5 times a week. And we want to go 70 to, so higher pressures bilaterally. So two cuffs on, cuff on each leg, 5 minutes on, and we went 5 minutes off. And I said, try for 3 cycles. This kid did it 5 times a week for 6 weeks. Goes into surgery, BTB, the bone tendon bone graft, comes out of surgery. 4 days post-op, squats to 90 degrees.
Wow.
Surgeon and PT both reach out. Like, what did you do with this kid? I'm like, I just shared information with him, right? He did everything. It was his consistency, like his quad activation off the charts, minimal atrophy and minimal swelling. I was like, okay, there's the power passive BFR. And basically, right, was just reading studies on how they're using passive BFR to offset atrophy for people who are immobilized. And I was like, well, there's an opportunity here, and it worked.
Yeah, I've read about that as well. It's interesting to see all the applications that get published lately.
Yeah.
Um, and to think about it, this actually didn't start here. It started in Japan.
1966. It's been around. I talked to a gentleman, and this really blew my mind, a couple weeks ago, who trained with Dr. Sato, I think for 15 years. Who Sato,
Wow.
as you know, everybody, he's the founder of BFR in Japan. And he told me, I was like, okay, who don't you do BFR with? He's like, I was like, what are your contraindications? He's like, I do it with everybody. I was like, what do you mean? He's like, well, in Japan, right, it's readily used in the hospital. So we have people seeing us. He's like, but I've done it with patients as young as 4, and I've done it with patients as old as 94. I've done it with people who are comatose. And what do? They're using lower pressures. They're
Yeah.
cycling on and off, right? And I was like, okay, that's amazing. Amazing. He's like, people working at their computer, put cuffs on, right? You're sitting at home during the day. You want to prevent atrophy. Out throughout the workday. You catch me, I'm running passive BFR pretty frequently. Or I'll inflate, go for a walk, and you feel the pump like
Yeah.
I'm walking by
It's the
myself.
it's the hormonal response that people need to understand. It's a complete
Yes.
different way of intensity, conceptually, right? As a person's used to lifting some type of external force to drive that intensity, this is an internal already load that you're not seeing, and you, as soon as you get to move, you start realizing it. It's like, oh, why this wasn't hard before. It's because of the occlusion, and you're not getting enough oxygen, and then there's a cascade of responses that happen after, you know. So yeah, I enjoyed this. Thanks a lot for taking the time out. Everyone, if there's any comments or questions, please feel free to leave them in the comment section. Thank you again.
Man, thank you, Marcel. I really appreciate the opportunity. Absolutely love talking about this.